talk about atrial fibrillation. This is a little bit different type of Zoom meeting, and that I have another participant with me, Colonel Charles Miller. And the Colonel's story brings to fore some of the difficult points about diagnosing and properly treating atrial fibrillation. We thought this would be a great time to talk about this. We're not doing elective procedures at Houston Methodist Hospital, the home of DeBakey. So of course, we have a little time. If you have atrial fibrillation and would like to get more information, this is the perfect time. It's good to get a second opinion, and the Colonel will tell us about that as well. Colonel Chuck Miller was in the Air Force. He's retired from the Air Force. He had a very distinguished career. He wrote a book that came out in the last, 8 months, Chuck, I guess, called Soaring with Destiny. You can get it on Amazon and usual places you buy books. It's really his story of working in the Air Force, and very distinguished, as I said. He also was asked to go to Canada at one point and teach the Canadians how to refuel jets in flight. So he spent a couple of years in Canada teaching them that. So he's got tons of stories, but he's also got an amazing AFib story. As many of you know who have AFib, sometimes you're told, well, you have AFib, you'll just have to live with it. Take these pills, take a blood thinner, and you'll be all right. But as many of you know, that's not the whole story. There are patients who develop heart failure and the dreaded stroke, which tends to be a big stroke with atrial fibrillation. Some AFib patients present with a stroke. And AFib is not a benign disease. So during the course of this next 45 minutes or so, if you have a question, you can get involved with this and text to DeBakey 37607. That's DeBakey 37607. Your question will come up, and we'll make every effort to answer your question. And you can ask these at any time. You do not have to wait till the end of this conversation. So I'm calling this a conversation with the Colonel, and he can tell us the trials and tribulations that he's been through, and also how he learned to find a solution that would keep his heart in rhythm. So that's a brief introduction. He's written a whole book. We could talk a lot about the Colonel, but Chuck, welcome to this podcast with DeBakey. And maybe you should start from the beginning. I remember you told me you had to go to the emergency room, and go ahead and tell your story.
Okay, Dr. Wolf, and thanks for having me on. Tell my story. I presented with AFib in 1991 at my age of 53 at the time. I had it for 13 years, from 91 to 2004. And I'll get into that story a little bit more detail as we go on. But as the AFib developed for me, it gradually worsened over the 8 years, the initial 8 years, until I was no longer in intermittent AFib, but in continuous AFib for 24/7. In my case, I was very symptomatic about it. I could feel it when it started. I could feel it when it quit. It would wake me up in the middle of the night in either event. And I was very much concerned about it after it got to the point that it was in a continuous situation, which it remained in for the last 66 months until I had the mini-maze done by you in 2004. During the time that I was in the AFib, I was prescribed 14 different drugs and combinations of drugs: Coumadin, warfarin, digoxin, Cunaglute, Tropol XL, Beta-Pace, Rhythmol, Cardizem, Diltiazem, Lopressor, Altase, Cartia, Metoprolol, Tambacor, and Amiodarone, as well as Coreg. the side effects of these drugs were extremely intense and horrendous and put my life quality down to near zero while I was taking those heavy doses of medication. Ultimately, I had toxic poisoning from a high dosage of 545 milligrams a day of flecainide, which occurred in December of 2003, at which time I had an ejection fraction of the heart by echocardiogram at 15%, where the normal is around 50 to 55%.
15% is heart transplantation range. And I'm stopping here just for 1 second because the first point that you have eloquently brought to our attention is that the drugs often start out at a low level, but slowly they keep increasing the amount of medication you take until you, as you said, you become toxic. Would you agree with that? You probably didn't start out at that dose, did you?
No, no. It was only after I got to the point of being in continuous AFib, which put me into congestive heart failure, i.e., because the atria was not beating in synchronization with the lower chambers of the heart. They were, in essence, circulating the blood internal to the heart rather than pumping it out to the various organs in the body.
Right. So first point for all of you listening is that very common for patients to be started on a medication for AFib. Oftentimes it does not work. And the reaction is, well, let's try a bigger dose. And then let's try a bigger dose. And I see a lot of patients that are just miserable, not only because they're in AFib, but because they're on so much medication. Go ahead, Chuck. Thank you.
Very, very much so. During that time frame, specifically after the initial couple of events, which were separated by about 16 months, I had 3 successful early chemical cardioversions. That was by intravenous visits to the ER emergency room. Subsequently, I had 2 unsuccessful electrocardioversions in May of 99 and July of 99. And by 1999, I had developed congestive heart failure and had been to the ER 5 times for the reason of that irregular and continuous heartbeat. That was followed in 2002 with a dual bypass surgery, which was a condition brought on by the AFib and congestive heart failure, and it was brought on by extremely cold weather, walking the dog, 15-degree weather. Go for a walk, and when I get about as far as I could get away from home, my heart was beating about double its rate, and I was starting to get angina, chest pains, and I had to go all the way back home before I had a place to cool off and get things back to normal.
Now, no, we're not blaming the dog, though, right?
No, we're not blaming the dog. We're blaming the medication and the AFib was the cause. I found that during that time period, the 13 years that I was in AFib in one form or another, I was practiced on by trial and error by 6 different cardiologists and 7 different electrophysiologists, all of whom I fired or left because I found great dismay about the fact that there were no 2 that seemed to have a protocol that was alike. They all wanted to try their own brand of chemical medications. I found amazingly that none of those offered any other options but the ones that they practiced specifically. The protocols of about half of the cardiologists was to treat only the symptoms and not the AFib. And that was one which
point.
by medication.
I'll interrupt you for a minute to remind people that in general, there are 2 grand schemes for patients that have continuous atrial fibrillation. One is just control the rate, tell the patient they have to live with AFib. The other is to try diligently to get the heart back in rhythm. Those are the two general ways to go about treating AFib. And usually in case like the colonels, after trying everything, they pretty much just say, well, you got to live with it. Go ahead.
Well, the situation of treating only the symptoms with the large and ever increasing amounts of different medications was that slowed the heart rate so that I couldn't feel the AFib. Slowing the heart rate took the wind out of the sails, destroyed my stamina and energy, led to lethargy and depression, and created numerous medical negative side effects that we've already touched on briefly.
Yeah, and just as an aside, some of these medications, as the colonel said, dramatically slow the heart rate, which makes you feel tired, and in some cases then leads to consultants saying, well, you need a pacemaker. But really, a lot of times, if you can get off those drugs, you don't need a pacemaker. Go ahead.
All right. Well, I discovered about this time frame, which was in December of 2003, a doctor locally in Cincinnati at the time named Dr. Randall Wolf, and he had a procedure that he developed. And that's when I came to know and love Dr. Wolf that we're talking to tonight, because he was one of the very, very few that offered some other alternatives. He offered some added insight into the nature of the disease, and he offered a potential fix, which for me definitely worked.
I remember having that conversation with you, even though it was a long time ago. Did you say that was 2005?
2004, October.
2004, wow. Yeah, it was a long time ago. And you had already had a bypass procedure. So from a surgical standpoint, that would be called a redo type of procedure. Even though it's minimally invasive, we might encounter scar from the previous operation. And I think we talked about that. And I think you'd gotten to the point where you really wanted a cure for this problem. And I told you, well, we'll put the scope in, we'll be able to see things, or the scar is too great and we won't. But we were able to see everything clearly and dissect out the heart and do what's now called the mini maze. It wasn't called a mini maze then. It was called bilateral pulmonary vein isolation and closure of the left atrial appendage. And there was another retired veteran, a veteran who said, Doc, you need a different name for this. And he's the one that named it the Wolf Mini Maze, George Ray. So the military has been involved in a couple of things here with the development of mini maze. Well, go ahead and tell us, after you saw me, what you decided to do and what happened.
Well, Dr. Wolf was the only doctor that put it square in my mind that AFib was not just some nuisance that I had to live with for the rest of my life. And probably my lifespan wouldn't be very long if I did. But he had a potential fix. And I'll let him tell you more about that if he has the time and initiative he wants to do that at this point. But as a result of the mini maze procedure at my age 76 and 13 years of AFib behind me, I found myself cured of all AFib, including no need for any AFib, medications or blood thinners. I had a post-op angiogram 4 years later, found that all the cardiovascular systems were open 100%, and that one of two of the bypasses that I had in the pre-mini maze situation had closed down because the bypass was no longer needed. It had cured itself. I also found that a year later, the post-op echo, my ejection fraction had gone from 15% up to 56%. And a stress test done 1 year later showed that my ejection fraction had gone to 59%. So I was better than new as far as I could tell from that standpoint.
Now, for people who might just have joined us, we're talking to Colonel Chuck Miller, explaining his experience with AFib. At the time that you had the mini maze procedure, you had already had atrial fibrillation for how many years, Scott?
13 years.
How many?
13 years.
13
the last 5.5
years.
of which are in congestive continuous or AFib.
And now, today, you are about how many years out from the mini maze?
2004, it puts me at 15 years.
Yeah, which is quite a story. Now, it's been my observation that people feel so much better after the mini maze. Some people say, I feel better than I have in 10 years. And for a while, I didn't understand that, because getting in rhythm should help, but why would they feel so much better? And finally dawned on me that probably half of it was getting back in rhythm, and the other half was probably getting off this ton of medications. What do you think about that, Chuck?
Well, I agree. I agree with that totally. And I found that the nature of being on the medication and in continuous AFib, that I got to the point that I didn't have the ambition or the desire to get any further than 5 minutes away from a telephone call that would get me an ambulance to the ER.
Yeah.
And when I woke up from the 3-hour procedure that I had, which was a little longer than normal because there were some adhesions from the prior bypass surgery that you had to take care of, I looked up at the monitor over my head and saw that normal sinus rhythm on there. And it just felt like a 10-ton weight was lifted off my shoulders, because now I didn't have that concern anymore. I could go out and travel and do things that I'd always wanted to do, but was unable to or felt incapable of doing because of being pinned down by the AFib.
One poor gentleman had a continuous AFib. He was a world traveler, and he had to stop traveling because he had hemorrhoids, and he was taking a blood thinner, and he had terrible problems with the hemorrhoids. He couldn't travel. Once he had the mini maze procedure, the appendage was closed. He didn't have to take blood thinners anymore. And he's also a very, very grateful person. It's not only it's the drugs that treat the AFib that slow you down, that slow your heart rate, that make you feel like when it comes to noontime, you're ready to lie down on the couch for the rest of the day. And it's also the problem with taking the blood thinners. Blood thinners have a lot of side effects. So and you were on both. You're on a lot of medications and the blood thinners. And I think we know that you've had echocardiograms from time to time. And I think all the way up to the last couple of years, you're still in the 50s for ejection fraction. Is that correct?
That's correct.
Which is fantastic. So you had AFib 13 years before, and since the mini maze, you're about at least 15 years out. You're staying in rhythm, and you got rid of a lot of grief. What are some of your observations? Oh, and by the way, if any of you are listening to this Zoom cast and you'd like to put a question to us, to the Colonel or to me, text DeBakey, D-E-B-A-K-E-Y, to 37607. And there are no bad questions. So if you're listening, just go ahead and send us a question. If you would like to talk to me offline sometime, that is fine as well. And I'll pull up a number here where you can call me during the daytime. And let's see if I have that number here. Number you can call during the daytime is, I don't see it right here, but I'll get it for you in a second. I'll give that to you. But if you'd like to query us, there it is, 713-441-5370. 713, that's the area code, 441-5370. If you'd like a 3-second opinion, I'm happy to do that for you. I talk to patients on the phone every day from around the country and outside the country. Last year at Houston Methodist, where I work at the DeBakey Heart and Vascular Center, I saw patients from over 26 states. So I see patients from around the country. They fly into Houston, have the procedure, and then fly back home. We also set up an arrangement with Dr. Pretorius in the Midwest in Cincinnati, Ohio, and I have a direct telehealth link with him, which can be seen on my phone, so I can see people in his office and he can see me in Cincinnati, Ohio. So I can talk to you by our telemedicine link. And we also have video link at Methodist, so I can give you a second opinion with a video link or a phone call, or I can do it through Dr. Pretorius's office in Cincinnati. Now, to be clear, all the procedures that I do are done at Houston Methodist at the DeBakey Heart and Vascular Center. But you don't have to come to Houston to get an opinion. This second opinion is free to anybody around the world. I applaud everybody who gets a second opinion for their AFib. You need to do your homework because, as Chuck, I think, has shown us, if you just stick with the system sometimes, it takes you down a deep, dark hole that doesn't go anywhere. Right, Chuck?
Absolutely. I'd like to say one thing, too, that is a unique experience for me, and I think that those of you that have dealings with Dr. Wolf will find a similar experience. Dr. Wolf is one of the few medical practitioners that I have found that makes it a point to put patient first and to establish a relationship with the patient and listen to what the patient has to offer rather than being a lecture source. And that made a big difference in my situation, because whenever I went to see the doctor, Dr. Wolf, I always came away from that meeting feeling that I was on the road to recovery and had a very bright and positive outlook, and was not left with the impression that I was told by a number of other doctors that I had dealings with prior to the mini maze, that the mini maze was not life-threatening, when I already had some experiences that told me quite the contrary with the congestive heart failure symptoms and the over-medication that I was experiencing. So,
Chuck, can you take a question from somebody?
Sure.
By the way, if you have other questions, text. Don't call, but text us to DeBakey to 37607. DeBakey to 37607. Chuck, this question is for you. And the question is, can the colonel describe what recovery was like from the mini maze? Now, I guess we should preface with saying you'd already had heart surgery, and most people will not do a mini maze on someone that's already had heart surgery, but I've done probably 30 now. You were one of the first, I think. I've done about 30 now, and it's very feasible. But anyway, the question to you is, what was your recovery like?
Well, in contrast to the heart bypass, it was about equivalent to having a wisdom tooth pulled, if that's severe. I was surprised that Dr. Wolf told me that basically in my recovery period after the surgery, that I had no limitations on what I could do other than what my body told me I shouldn't do. In other words, he gave me no formal restrictions and said, if it doesn't bother you, then go ahead and do anything you want to do. If it does, then take it kind of easy. Certainly, I was given the caution, don't exert yourself excessively for the first 2 weeks or thereabouts. But there wasn't any major restrictions in what I could eat or what I could do. It's just what I felt comfortable doing. The nature of the minimally invasive surgery that was done in the mini maze means that no major muscle groups are severed in the surgery, and therefore you don't have a lot of healing pain involved with the surgery. So you feel weak, as you would expect to with major surgery of that type, but you didn't feel like if you moved too quickly, you were going to pull something loose or tear something.
Well, unfortunately, you had the experience of having both open heart surgery and minimally invasive surgery. So you're the perfect person to ask that question. With the open heart surgery, of course, for those of you in the audience, it's done by usually going through the breastbone. And that's a bone like any bone. Like if you break a bone in your leg, it takes 6 weeks to heal. And it's makes it difficult to cough for things. As opposed to the mini maze, where the biggest incision is usually about the end of my 3 fingers is the biggest incision between the ribs on each side. The heart is not stopped. There's no heart-lung machine. There's no anticoagulant used. So it's done on the beating heart by using a scope and small incisions between the ribs. And the incisions, if you lift up your hand, lift up your arm and put your hand in your armpit, that's where the incisions are on each side of the body. So there are small incisions on each side. I usually do the right first. It usually takes about 45 minutes. Then the left, and that takes about 45 minutes. And a couple of points that I might like to emphasize. When I first started doing this, the goal was to do a pulmonary vein isolation, make a line around the pulmonary veins. And along with Mike Hooven and some engineers that were very brilliant, we had designed a clamp that would make these lines around the heart in about 15 seconds, as opposed to a catheter ablation, which can take 5-6 hours. So we could make these very quickly, and they would be complete lines isolating the pulmonary veins. But then while teaching a surgeon at the University of Oklahoma, I interacted with the electrophysiologist there and happened to go by a lab where Ben Sherlog was working and on animals. And he was showing that if you injected alcohol on the outside of the heart around the pulmonary veins, and there was AFib in the animal, the AFib would stop like that. Alcohol injection into the fat on the outside of the heart around the pulmonary veins would stop AFib in a finger snap. And I was amazed and intrigued. And ultimately, I brought Ben and his setup to, at the time I was at the University of Cincinnati, and we started testing these areas on the outside of the heart in every mini maze patient and ablating these little fat areas next to the pulmonary veins on the outside of the heart. Now, you can't get to the outside of the heart with a catheter ablation through the groin, but with the mini maze, we see them with the scope beautifully. As it turns out, these fat pads outside the heart around the pulmonary veins are absolutely loaded with nerves. They're loaded with nerves. These are the nerves that make your hands sweat when you look over the edge of a tall building. They're the nerves that make your heartbeat go very quickly when you're watching a scary movie. Why should your heart rate go up when you're watching a scary movie? You're not running. It's these autonomic nerves that do this fight or flight thing that's been with us for millions of years. So it became important to me to test these nerves and treat the nerves. And I'm one of the physicians, along with others, who believe that burning up the heart is not the answer to treating AFib. It's isolating these nerves on the outside of the heart that stimulate right around the pulmonary veins and cause the AFib. So the beauty of the mini maze is we still do an isolation of the heart better than you can do with a catheter, but we also isolate these little nerves on the outside of the heart. And I believe that one of the reasons the mini maze has such a high AFib free rate. In our review and other people's reviews from around the world that have done this now, and I've taught people how to do this in over 20 countries, and there are reports from all over the world. Generally, you get 80 to 90% AFib free rate at 1 year. And in our situation, we've looked out to 6 years and it stays the same, of no AFib at 1 year. over 90% if the heart is in and out of AFib. And the kernel situation where you're when you're in AFib all the time, we're still getting an AFib free rate of around 85%, which is very good. The catheter ablation rates for continuous AFib are probably half that. In addition, from the very beginning, based on previous literature from Dr. Cox and others, it seemed very important to close the ear on the heart, the left atrial appendage. The left atrial appendage, when we're in the womb, is at one time the back of the heart. But as the pulmonary veins grow into the heart from the lungs, that back of the heart moves over to the side and becomes the left atrial appendage. It doesn't have much function, but that's where clots form. And in the audience right now, if you're taking a blood thinner for AFib, you're taking a blood thinner to stop blood clots at one place. Where is that? The left atrial appendage. So then it makes sense, it's logical that if the left atrial appendage is closed, then you don't need to take a blood thinner. And you decrease your risk of stroke from AFib by 97%. So from the get-go, including in the kernel's case, the appendage is closed, so you don't have to take blood thinners anymore, and you decrease your chance of blood clot. If you're taking a blood thinner for AFib, you're decreasing your risk of stroke by 60%. If you close the appendage with the mini maze, you decrease the risk of stroke by 97%, and you don't have to take blood thinners anymore. So the mini maze is closing the appendage, doing a pulmonary vein isolation, and addressing these nerves on the outside of the heart, which I believe in most cases start the AFib in patients who have what we call lone AFib. So it's an important point. It's a lot different from just doing a catheter ablation. There was one study that looked at 55 patients on each side. 55 had a catheter ablation, 55 had the mini maze. And then at 1 year, they looked to see what percent of patients were in rhythm. The number of patients in rhythm in the mini maze group was twice as many as the catheter ablation group. There was one death in the whole study, and that was in the group that had catheter ablation. There were no deaths in the mini maze group. So it works well. A lot of people don't know about it or understand it, but we thought talking to someone who's been through everything, a very long history of AFib, 13 years, bypass surgery, and then the mini maze, and then another 14 or 15 years since then is quite a story. Now, I'd like to take a break because I don't want to do all the talking, and tell us other thoughts you have, recommendations you have, Chuck, to patients who are suffering maybe in one of the stages that you've gone through. It could be intermittent AFib, could be continuous AFib.
Well, I guess one of the lessons that I've learned, and I've learned it the hard way, excuse me, is that if you're not satisfied with what you're hearing, by all means, get a second opinion. And there are many doctors out there that can give you some good advice on the second opinion. And if you ever find a doctor that balks at you asking for a second opinion, you know immediately to jump, because he's not sure of what he's telling you if he's not willing to listen to somebody give a second opinion. And I got a second opinion way back in the beginning when I had gone through the process of trying to get it under control with the more conventional means, including a period of time at Cleveland Clinic, which was unsuccessful in stopping the continuous AFib that I was experiencing. And the bottom line to all that discussion was that by going out and asking for a second opinion online from the Cleveland Clinic's team of doctors, I had 3 doctors that gave an opinion based on my verbal inputs onto what my experience was that 2 of the 3 said they agreed that my circumstances were not being properly treated by looking for stopping the symptoms as opposed to stopping the AFib itself. And that's one of the things that really put the coal under my feet when I found out Dr. Wolf in Cincinnati had developed a process and that he might be an answer for me to consider. And he surprised me because at the time he was in his first year of doing human patients. I believe I was your 39th patient in that process. I was probably the first one that had a bypass surgery done prior to that, and some of the other things that went along with that. And I felt that you were going to discontinue or discount my plea for help based on the fact that you were working on trying to get a good platform of numbers and records in your process. And when we talked, and I told Dr. Wolf how serious I was about undergoing the mini maze as a last chance operation, he said, well, let me think about it. And the next thing I heard from him was from his deputy in charge. I can't remember her name, but his assistant. And she had an appointment for me for the end of that month to have the mini maze procedure done.
Could have been Denise. Maybe it was Denise. I don't remember. Maybe it was Denise. I don't remember.
I don't think it was Denise. It was the
Nessie.
The real dark hair and Italian.
Nessie. Yeah, Nessie.
Nessie.
Maybe.
Yeah. Nessie.
Right. So for those of you out there that say, well, I've had AFib continuously for such a long time, probably can't do anything, I also offer just closing the appendage. And the advantage of that is we can get you off the blood thinner. You still have AFib, but you don't have to take the blood thinner anymore. So that's just the left side procedure, and that takes about 30 minutes. I did one lady this last year who's 90 years old. I guess she's older than that now. And she was in the hospital for 2 days after her closure of her appendage, and she doesn't have to take blood thinners anymore. For those of you who can't take blood thinners who have AFib, this is a very good option for you. And compared to some other ways to close the atrial fibrillation, close the appendage, such as the Watchman device, the way we do it with the mini maze is much more secure. It's a complete closure, and you don't have anything inside your heart, which is what happens with the Watchman. So it's something to look at if you're thinking about it. Now, another important point that comes out from listening to Chuck, I have to remember to impart to you all, is that Chuck had AFib for 13 years before the mini maze. So in a lot of places, if you ask the doctor, well, I've had AFib for 13 years, can I have the mini maze? They'll go, absolutely not. Not after 13 years. But the important thing is not how long you've had AFib, how long has the AFib been continuous? And in my experience, if the AFib has been continuous for less than 5 years, or about 5 years, and the left atrial size is less than 5.5 centimeters, then you're still a candidate for this procedure. I'm reminded of a gentleman who worked in Cincinnati, vice president of a company, and his left atrium was larger than 5.5 centimeters. His heart had dilated quite a bit from the AFib, but he'd only been continuous AFib for 6 months. And he's also more than 10 years out from the procedure and staying in rhythm on no medications. So it's important to take a good history. The length of time that you've been in AFib is not as important as the length of time you've been in continuous AFib. That's the key part, and getting an echo to see the size of the left atrium. You also bring up another important point, Chuck, and the way I say it is the same, but the only physician you should be concerned about is the one that doesn't want you to get a second opinion. And you get a third opinion, especially when you have a chronic disease like AFib. Now, if you have appendicitis, you can't get a second, third opinion. That reminds me of a joke. I saw this cartoon. It was a patient on the examination bed in the doctor's office. There was a physician there with a white coat on, and the physician says, "Well, I think you got appendicitis, but if you want a second opinion, I'll say it's your gallbladder." So second opinions are important, and you should do your homework. Unlike a acute problem like appendicitis with AFib, you have time to do your homework. And gosh, Chuck, you had a lot of time, suffered for 13 years. Amazing. Again, Colonel Miller's book is Soaring with Destiny. I guess it's on Amazon and places like that. Is that right?
Yes.
You do mention a little bit about your AFib journey in your book, correct?
Yes, I didn't write that in there to any great extent because I wanted to talk about the historical side of what I was doing in the Air Force. But I did bring it in because it did play a role in things that I did during my Air Force career. Although it was all my AFib began 10 years after I retired from the Air Force, so it did not prove to be a detriment during my time in the Air Force.
And that brings up another good point. It could have, because I do see a fair number of people who are pilots. And as you probably well know, when they get AFib, they can be grounded. And that's their whole livelihood going down the drain. So many of them have come for the mini maze. I did meet with the FAA in Oklahoma City a year and a half ago, because they noticed that pilots who had AFib, who had the mini maze, got off the medications, were AFib free and could fly again, as opposed to some of the other treatments for AFib. So it's been a very good treatment for patients who are pilots who want to get back up in the air and pass their flight physical. And I've been told by several pilots that after the mini maze and after being checked every 6 months a couple times, they've been put back on the regular checkup, which I understand is once a year, which I guess is as good as you can get.
Yes.
Whereas if you have a continuing medical problem, such as AFib, after treatment, then you have to be checked more often than once a year. Is that correct?
To my knowledge, yes.
Yeah. So it's been very beneficial for private and commercial pilots who come to Houston and had the mini maze under our care. Again, happy to do a second opinion for anyone. You can contact us through this site. You can also go to wolfminimaze.com. That's my name, no E, W-O-L-F, wolfminimaze.com. And you can contact me there and do a second opinion. You can do it through the DeBakey site. You can do it through the Houston Methodist site. This is a great time to get a second opinion, why we are holding off on elective cases until the COVID-19 dies down. For those of you who've been listening to this podcast, God bless you all and stay safe. Right now, the hospitals are very, very busy with viral patients. And thank goodness we've shut down all the elective procedures. Hopefully we'll get over this hump soon. Once we do, we'll be able to see people again directly. I'd like to take one last question before we close. As soon as it comes up here on the screen, again, that's texting. It's DeBakey to 37607. And as soon as this question comes up, I'll give it. Any other thoughts you might have that we didn't cover. I interrupted you several times, but you give such a compelling story that it makes me think of these points as you were talking.
Let me make one point that it'll be a little bit offline, so to speak, and that is that I have discovered, in my own experience, I've discovered the cause of AFib. And the cause is easy to talk about in that sense because it is a very complex issue. That one thing that's in common with every AFib experience that I've ever had, and most that I've talked to people about, have one thing in common, and that's high level of stress. And that manifests itself The reason it's very complex is your human body is a very complex chemical factory. And when you get stressed, your adrenaline kicks in and starts fooling around with the various chemistry and anything else that might do the same thing, whether it be alcohol or food allergies or too much exercise or an injury someplace else in the body. Any of those things can trigger an AFib episode. And once it's triggered, it's like a hole in the dam, and it's something that can grow over time because it has found a weakness. And the thing that I have found in all of this, and in a moment of self-disclosure, I've also not been AFib free for 15 years. As you know, after 10 and a half years of being totally free of AFib, I had a short period of about 6 months where I had 3 episodes of AFib.
Mm-hmm.
When I was under very intense job-related stress. And I went through 3 successful cardioversions. First shot was the only thing it took to bring me out. And I'm still, that was in 2015. In the last 5 years, I've had no further issue at all with the AFib after 10 and a half years of being AFib free. Before that,
that's a great point, and I agree with you. And that's the nerves that are on the outside of the heart. It's called vagal AFib, and really that's what I think kicks the heart out. And it is generally stress related, I believe. And there's an imbalance of these nerves. Some of them are sympathetic, some are parasympathetic. And now I'm able to test those, and I did it in your case with a probe where we touch down on the heart and we can find these little nerves. And when we stimulate them with a tiny bit of electricity during the mini maze, not enough you can even feel it with your finger, the heart will just stop. And then you stop stimulating and it starts beating again. That's got to be important. When we finish the mini maze, we stimulate those areas, no response. So I hope one day we'll find out that it's not burning up the heart that's important. It's interrupting this autonomic nervous imbalance, these nerves that are around the heart. The heart is surrounded by thousands of tiny nerves. These aren't the nerves that make your muscles twitch. These are these autonomic nerves. So here's the last question. The question is, do you also use this procedure on patients with paroxysmal atrial fibrillation? So what Chuck had for many years was paroxysmal atrial fibrillation. Finally, it turned into continuous atrial fibrillation, which means the heart wasn't in rhythm anytime. But what about the patients who don't have AFib all the time? The mini maze is even better for those patients because we're catching the disease a little earlier. So our highest cure rate is in patients who have paroxysmal AFib. We run 92% AFib free at 6 years if they have paroxysmal AFib. The heart's not as dilated. The ejection fraction is normal, unlike with the Colonel's case, where the ejection fraction had already gone down. So the paroxysmal cases do amazingly well. So the answer is absolutely, we can do any type of AFib. They're candidates for the mini maze, or they can be candidates. Some people say, what if I've already had an AFib stroke? Can I have the mini maze? Yes, the answer is yes. What if I've already had a catheter ablation, or 2 catheter ablations, or 3 catheter ablations, or 4 catheter ablations? We've done patients with 5 catheter ablations. The answer is yes. Mini maze can still be very helpful.
How about if you're an old guy or an
old guy? Yeah, the oldest patient I've done is 90. So it's not the chronologic age, it's the physiologic age that I think is most important. But we've not limited our procedure to anyone of any age. The youngest patient, believe it or not, was 15, Chuck. Some people develop AFib at a very young age with a strong family history. By the way, did you have any family history?
None that I'm aware of.
Yeah.
Never had anybody in the family that had AFib.
Well, I hope this has been helpful to the people that are listening, this will be archived. It'll be available on the website. Go to DeBakey. This is coming from DeBakey Heart and Vascular Center. Colonel Miller, thanks so much for sharing your story with us. I think it can really help people who struggle with AFib. Thank you for writing the book, Soaring with Destiny. If you want to hear, it's a detailed book about your life and also about flying some of the biggest planes in the world and how to refuel in flight, which is an amazing thing to me even today. Thank you for your service to our country. I know you also served in different functions after that. Thank you for doing that. And thank you so much for sharing with people. If they want to get your opinion on something, is it all right if someone contacts you through your website or not website, but your email?
Yes, I've done that many times, and I'm more than happy to share my knowledge and anything that would help somebody have a better outlook on what their chances are.
How can they email you?
Well, I've got a very lengthy email address. It's phonetically, it's aviator.USAirForce, USAF @Gmail. I'll spell it out for you. It's AV letter, the number 8, OR .USAF @gmail.com. And if you need to find that again, you can look it up. I believe it's still on your website, Randy.
Okay.
My update address.
wolfminimaze.com. Yeah,
Yeah.
wolfminimaze.com.
And also buy my book, and it's in the book.
All right. Colonel Miller, thanks for your service. Thanks for your sharing your story with everybody. And please stay safe and well. Ladies and gentlemen, that concludes our program. Thank you so much for listening. Take care, everybody.
Thank you, Dr. Wolf.